DS from Shamtiram, MS from Shamtiram. I request Sravya to take over the session, and she is like my child.
Thank you, madam, for the sweet introduction. Hope you are all enjoying the nice academic feast since morning. And I know that we are running late of the time, and it's a pre-lunch session. So I'll not take much of your time. I'll complete it very fast. And then till now we have seen all the vaginal hysterectomies, abdominal hysterectomies. Now I just want to throw light on vaginal hysterectomy in post-cesarean sections. Procedure in which uterus is surgically removed through vagina. Ovaries and tubes can also be removed during this procedure. It is called bilateral salpingo-oophorectomy. Vaginal approach may be used if the uterus is not greatly enlarged and not related to cancer. It is called non-distant vaginal hysterectomy. And what are the indications for vaginal hysterectomy? Prolapse, abdominal uterine bleeding, fibroids, cervical abnormalities, endometrial hypoplasia, and chronic pelvic pain. What are the steps of surgery? First, anesthesia. It may be spinal or epidural or general, and then it can be combined spinal and epidural. Position, we prefer lithotomy position and terminal birth position. And assessment under anesthesia, downward mobility of uterus and size of the uterus, and also adnexa. What are the steps of vaginal hysterectomy? Under strict aseptic precautions, patient parts are painted and taped, catheterization of empty bladder is done, and then the cervix is grasped and saline is injected with or without epinephrine below the vaginal mucosa. This is called hydrodissection. This is done to minimize the blood loss during the dissection. We use 10 to 15 ml of diluted saline solution containing vasopressin. This can be injected circumferentially along the incision site. This method also helps to separate facial plane and dissection make easier. What are the steps of the surgery? Incision is made below the lower edge of bladder dissection of vaginal mucosa, and posterior colpotomy is done, which gives us the entry into the pouch of Douglas. After pushing of the bladder and opening of POD, first clamp is applied to uterosacral ligament as close to the uterus as possible. The uterosacral pedicle threads are kept long for further identification. These are the pictures. Anteriorly, the uterovesical fold of peritoneum is open and bladder is pushed up. Uterine vessels are clamped. Uterovovarian ligament is identified and fallopian is also clamped. Repair is continued by doing caldoplasty, peritoneal closure and vaginal closure. The first external suture is placed through the full thickness of posterior vaginal wall. This incorporates the posterior peritoneum and uterosacral ligament. Caldoplasty. This is done for supporting the wall with uterosacral ligaments and prevent wall prolapse in future. Peritoneal closure. The bursting suture bites taken on peritoneum above the level of stitches on the pedicles. Tying the two uterosacral ligaments together, this provides support to the base of the bladder. Anterior colporrhaphy. This is called cystocele repair. The repair of tears in tubocervical septum, repair of tubovesical fascia, removal of extravaginal tissue, closure of vaginal wall with absorbable sutures. External caldoplast suture are now tied to lift up the wall of vagina. This is a cystocele repair picture. Posterior carpoperineoplasty. This is done to reduce the rectocele and also perineal body repair. We separate the rectum from vaginal mucosa, identify levator ani on both sides and guide them. Together, this repair tone perineal body also. Repair of tears in rectovaginal fascia. Removal of extravaginal tissue and also close vagina and perineal skin. This is a picture. What is the post-operative care? Vaginal pack optional if colpoperineoplasty is done. Follis catheter is done for 24 to 48 hours. Nil per oral is allowed for 12 to 24 hours. IV fluids, painkillers and antibiotics. Peri-operative complications. Hemorrhage, infection, constipation, urinary complications, retention of blood clots, damage to adjacent organs, early menopause, prolapse of vaginal wall and this. What are the advantages of vaginal hysterectomy over total abdominal hysterectomy? early resumption of day-to-day activities, post-operative complications are less post-operative pain, less need of analgesia, less morbidity and mortality, can be done effectively obese patients. What are the disadvantages? We need a skilled surgeon, and the exploration of abdominal and pelvic organs cannot be done. Difficulty with restricted mobility due to adhesions, difficult with uterus size more than 12 weeks, and difficult to tackle with tubal and ovarian pathology. So, thank you. Hope you have a nice session. Thank you. Thank you for giving me this opportunity.